So the first question of imaging is to answer the question, where is the tumors? What area should we irradiate it? For example, in lung cancer, there was an enormous progress by the use of PET-CT with FDG, because when we use PET-CT, we know that the GTV, the tumor volume, is smaller. And also we can identify the nodes, the mediastinal nodes, which are invaded. And therefore we can irradiate a smaller volume. And the side effects are therefore less pronounced. So that's the main advantage of imaging in the past. And I think now molecular imaging is trying to answer the question, what is the best treatment for this specific patient? So there's slightly different questions. For example, do we have to use palliative treatment or curative treatment? Do we have to use targeted agent, immunotherapy? And there are different methods. There's more complicated and expensive molecular imaging, for example, by using specific biomarkers like antibodies of HX4, or you have more simple methods based on like radiomics, which is a little bit the poor man molecular imaging. And I think we need both approaches. Well, the main challenge really, I think, is the access to data. Because to do a proper imaging study, you need a large volume of data, but you also ideally need data from other centers to make sort of external validations. And then it depends which approach you use. If you want to use new hardware like MR or dual energy CT, that costs some money. Or if you want to use new biomarkers like HX4 of labeled antibody, that's quite complex to do. You need an experienced pharmacology department. And if you want to use radiomics approach, that's a little bit easier, it's cheaper, but you need to use the right approach because you need to use the right methodology because there is a risk of overfitting. The future will be combination with systemic treatment and in particular with immunotherapy, because we've seen that with immunotherapy we have abscopal effect, which is very interesting, but also memory effect. This means that when the patient is cured for a long period of time. And also we shouldn't forget that cancer is a systemic disease. And radiotherapy is a local regional treatment. So we really need, especially in lung cancer, to combine that with systemic treatment. And I would say, in first instance, the most promising at the moment is immunotherapy. So when I started in Maastricht, I became head of the department, and I've been head of the department doing 15 years. So that's quite a long period. And then when I started, we had about 100 employees, and 15 years later, 400 employees. So that's quite exhausting. And my real passion is more research. So I thought that I've done my work after 15 years. It was the right moment to do something else. Yes, I remember when I started radiotherapy 20 years ago or more, some colleagues told me that this discipline would disappear, would be replaced by systemic treatments, but radiotherapy actually made a huge amount of progress. So I think I don't have any regret to have chosen that discipline because it's a combination of physics, biology, clinics, and also big data. I would certainly, it's very interesting to do research, because we are in a field which progresses very quickly. And then if you can manage to do the combination of clinical activities and research, that's really exciting. Well, perhaps not everybody knows, but I have 7 children. Which, yes, so I know for the Chinese standard, it's quite unusual. And it's actually a very good training to become head of a department, because with 7 children, there's always problems, there's always a financial deficit, You cannot get rid of them. You have to keep them. So when you can manage 7 kids, you can also manage a department of radiotherapy.